There's a strain of Ebola for which no approved vaccine exists, not the strain you heard about in 2014, not the strain that dominated the headlines during the West Africa outbreak that killed 11,000 people. A different strain, Sudan Ebola virus. It has been killing people in Central Africa in recurring outbreaks for nearly 5 decades. And the last time it crossed into a country that shares an airport with the rest of the world, a traveler boarded a plane, flew to a major international hub, went to a hospital, was admitted, and the entire contact tracing operation that followed cost hundreds of millions of dollars, occupied thousands of health workers, and ended with a confirmed case on American soil. That happened before. The conditions that made it happen still exist. The vaccine that would stop it does not. Here is what this video covers. Most people who remember Ebola remember the 2014 outbreak, the West Africa epidemic, Guinea, Sierra Leone, Liberia, the footage of hazmat suits, the fear. What most people do not know is that the outbreak they remember, the one that killed 11,000 people and reached the United States, was caused by Zaire Ebola virus. And for Zaire Ebola virus, a vaccine now exists. It works. It has been used in multiple outbreaks in the DRC since 2018. It has saved lives. But here's the detail that no mainstream coverage explains with sufficient clarity. There are 6 species of Ebola virus. The vaccine protects against 1. Sudan Ebola virus, the second most lethal strain, responsible for multiple outbreaks across Uganda, Sudan, and South Sudan, has no approved vaccine, no licensed treatment, no ring vaccination protocol that health workers can deploy around a confirmed case. When Sudan Ebola virus appears, and it has appeared again and again since 1976, the response is contact tracing, isolation, supportive care, and the hope that the outbreak stays contained before it finds an airport. In 2022, it did find an airport. An outbreak in Uganda's Mubendi district killed 55 people and sent contact tracers racing to track every individual who had passed through the affected region. One of those individuals had already traveled internationally. The chain was broken in time. That time. Stay with me. Because the question this video is going to answer is not whether Ebola can reach the United States. It already did. The question is whether the system that stopped it last time is adequate for what is building right now. And the honest answer from the people who run that system is, not entirely. Ebola was first identified in 1976, 2 simultaneous outbreaks, one in Nzara, Sudan, one near the Ebola River in what is now the Democratic Republic of Congo. 2 separate strains, identified in the same year, both lethal, both hemorrhagic. The Zaire strain, named for its country of first identification, had a case-fatality rate in that first outbreak of approximately 88%. Nearly 9 in 10 people who contracted it died. The Sudan strain had a case-fatality rate of approximately 53%, still catastrophic, still one of the most lethal naturally occurring pathogens on Earth, but lower, and therefore, in the calculus of research funding and vaccine development, less urgent. The Zaire strain drove the 2014 West Africa epidemic. The Zaire strain generated the international response, the emergency funding, the accelerated vaccine trials, the political will that produced Ervebo, the first licensed Ebola vaccine. The Sudan strain drove outbreaks in 1976, 1979, 2000, 2004, 2011, 2012, 2022. 8 outbreaks, hundreds of deaths, and no licensed vaccine. Not because the science of Sudan strain vaccination is impossible. Candidate vaccines exist. They are in clinical trials. Some showed promise during the 2022 Uganda outbreak, deployed under compassionate use protocols before licensing. But compassionate use is not a vaccination campaign. It is a research intervention in a crisis, administered to a limited number of consenting participants in a controlled setting. It is not the ring vaccination protocol that health workers can use to build a firewall around a confirmed case the way they can with Zaire. When Sudan Ebola virus appears in a community, health workers arrive with contact tracing protocols, personal protective equipment, and isolation capacity. They do not arrive with a proven vaccine they can deploy at scale. That asymmetry between what the global health system can do for Zaire Ebola virus and what it can do for Sudan Ebola virus is the gap that the current situation is testing. This is not theoretical. In September 2014, Thomas Eric Duncan traveled from Liberia to Dallas, Texas. He was not symptomatic when he boarded the plane. Ebola's incubation period runs from 2 to 21 days. He had been exposed to an infected individual in Monrovia. He did not know he was infected. He flew to Brussels, then to Dulles International Airport, then to Dallas, Fort Worth. He stayed with family. 4 days after arriving in Dallas, he became symptomatic. He went to Texas Health Presbyterian Hospital. He was sent home with antibiotics. 2 days later, he returned by ambulance. The diagnosis, Ebola. The response, the largest Ebola contact tracing operation ever conducted on American soil. Approximately 100 people required monitoring. 2 nurses who treated Duncan Nina Pham and Amber Vinson, contracted the virus. Both survived. Duncan died on October 8, 2014. The outbreak was contained, but the mechanism was completely documented. A sick person, an international airport, a domestic flight, a hospital that did not recognize the presentation immediately. That mechanism has not been closed. International airports still connect outbreak regions to the United States within hours. Screening protocols at ports of entry, temperature checks, symptom questionnaires cannot detect a traveler who is infected but not yet symptomatic. The 21-day incubation window is longer than most international flights. A person exposed to Sudan Ebola virus in an outbreak region today could be on a connecting flight to any major American city within hours and not show a single symptom for another 2 weeks. The entry point is not the airport screening desk, it is the emergency room. The place where a patient with fever, fatigue, and gastrointestinal symptoms presents, and the differential diagnosis includes influenza, food poisoning, malaria, and Ebola, if the clinician thinks to ask where the patient has been in the last 3 weeks. That question, the travel history question, saved lives in Dallas in 2014. It was asked too late the first time Duncan presented. It was asked correctly the second time. The system has one data point on how it performs under real conditions. That data point is Thomas Eric Duncan. Sudan Ebola virus has emerged repeatedly from a specific geographic corridor. The border regions of South Sudan, Uganda, and Sudan, a zone of equatorial forest and savanna grassland where the natural reservoir of Ebola virus is believed to exist. The reservoir, the animal species that carries the virus without dying from it, is believed to be fruit bats, though this has not been definitively confirmed for all Ebola virus species. The spillover mechanism, the moment when the virus moves from the reservoir to a human population, typically involves direct contact with infected animals or contact with an infected human during care of the sick or preparation of the dead. Funeral practices that involve direct contact with the body of a deceased person have been documented as amplification events in multiple outbreaks. The virus spreads through direct contact with the bodily fluids of a symptomatic or deceased individual, not through the air, not through casual contact, not through water. This is both the biological fact that makes Ebola containable in principle, and the fact that is most commonly misunderstood by a public trained by COVID to think about respiratory transmission. Ebola does not spread the way COVID spreads. It spreads the way hepatitis B spreads, through blood, secretions, organs, or bodily fluids, but with a case-fatality rate that in the Sudan strain kills approximately 1 in 2 untreated patients. The conditions in the outbreak regions where Sudan Ebola virus emerges, limited healthcare infrastructure, cultural funeral practices involving body contact, high levels of movement between rural communities and regional market towns, are conditions that favor outbreak amplification before a case reaches formal health attention. By the time a confirmed case is reported to the Ministry of Health, the chain of transmission is typically already multiple generations long. The contacts of the index case have already dispersed to other villages, to regional towns, to the capital city, to the airport. The World Health Organization's Global Outbreak Alert and Response Network, GORN, maintains continuous surveillance of infectious disease events across 193 member states. The CDC's Emergency Operations Center operates 24 hours a day, monitoring disease intelligence from field stations, partner agencies, and open-source disease surveillance systems like ProMed and HealthMap. When an outbreak is declared, when a country's Ministry of Health officially notifies the WHO of a potential public health emergency of international concern, the international response system activates. Incident management structures, rapid response teams, logistics prepositioning, contact tracing support, laboratory capacity deployment. The system has been built and refined through every outbreak since 2014. It is better than it was. Here is what officials in the global health surveillance community will say candidly in conversations that are not public briefings. The surveillance system is only as good as the speed at which outbreak-affected countries report to the WHO. There are documented cases in every major outbreak of a delay, sometimes days, sometimes weeks, between the first cluster of cases and the official notification, political considerations, fear of trade and travel restrictions. The time required for laboratory confirmation to distinguish Sudan Ebola virus from other febrile illness causes. In that delay window, between first case and official notification, the outbreak moves, people travel. Contacts disperse. The ring vaccination option that does not yet exist for Sudan strain would need to be deployed but cannot be. The CDC's global health security programs, the ones that fund in-country laboratory capacity and epidemiological workforce training, have faced funding constraints in multiple budget cycles in the past decade. The international health infrastructure that provides early warning is present in the highest risk countries. It is not uniformly funded at the level the risk warrants. The system works until it doesn't, and when it doesn't, The first indication is a patient in a foreign emergency room with a fever, a travel history, and a presentation that looks like something more common than it is. Here is what officials are not framing clearly. In 2014, the United States designated 58 hospitals across the country as Ebola treatment centers, facilities with the training, the personal protective equipment, and the isolation capacity to manage an Ebola patient safely. 58 hospitals in a country of 330 million people, with approximately 6,100 hospitals. The protocol is a patient presenting with Ebola symptoms and a relevant travel history should be identified at the primary care or emergency room level and transferred to one of the 58 designated facilities. The protocol assumes that the travel history is elicited, that the clinician thinks to ask, that the patient accurately reports their travel, that the emergency room that first sees the patient is not one of the 6,042 non-designated hospitals in the country, or if it is, that the clinician there still follows the isolation protocol while the transfer is arranged. In 2014, Texas Health Presbyterian Hospital was not a designated Ebola treatment center. It was a well-regarded community hospital in a major American city. It missed the diagnosis on the first presentation, not because of negligence, because Ebola in Dallas was not something the differential diagnosis was calibrated to include without explicit clinical prompting. Since 2014, training has improved. The clinical awareness of Ebola as a diagnosis to consider in febrile patients with relevant travel history has increased. But clinical awareness is not the same as preparedness, and preparedness is not the same as readiness. Readiness is what exists in the 58 designated hospitals on the day a patient presents, the PPE that has been maintained, the staff that has been trained recently, the protocols that have been drilled, the isolation rooms that are fully functional. Institutional readiness is the first thing that erodes in the years between outbreaks. When the threat seems distant, the drills seem unnecessary. The PPE stockpiles seem expensive to maintain. When the threat was last present in 2014, 10 years ago, the readiness was acute. In 2025, it is a question that each of the 58 hospitals answers differently. Start at the outbreak region. A confirmed cluster of Sudan Ebola virus cases in an East African country with international airport access. The WHO notification goes out, the CDC Emergency Operations Center activates, contact tracing begins, isolation capacity is deployed, and simultaneously, because the notification came after the delay window, individuals who were in the outbreak area during the exposure period are no longer in the outbreak area. Some are in regional capitals. Some are in international hubs. Nairobi, Addis Ababa, Dubai. Some have connected onward to London, to Paris, to JFK, to LAX, to Chicago O'Hare. The contact tracing operation that follows is conducted across multiple countries simultaneously. Coordinated by the WHO's GORN network, the CDC, and the health agencies of every country where a potential contact has traveled. Move outward. The media coverage of a confirmed Ebola case in a Western country, the first case in the current outbreak, does not produce proportional response. It produces disproportionate fear. The 2014 Dallas case triggered protective behaviors across the United States that were not calibrated to the actual transmission risk. Hospital avoidance, cancellation of travel, calls for flight bans from affected countries. The measure that global health experts uniformly opposed because it reduces the ability to get response workers into outbreak regions. The economic disruption from Ebola fear in 2014 cost the West African economies an estimated $2.2 billion. A significant portion of that loss was not from the outbreak itself. It was from the response to the fear of it. Move outward further. A Sudan Ebola virus case confirmed in a major American city, with no approved vaccine to deploy, with contact tracing operations crossing international jurisdictions, with a public that experienced COVID and has been primed to interpret infectious disease news through a pandemic lens, produces a public communication challenge of a specific complexity. How do you say this is serious, contained, and manageable without triggering the behaviors that make it harder to contain? How do you say the risk to the general public is low without triggering the dismissal that produces failure to report? The communication challenge is as technically difficult as the epidemiological one, and it has to be executed in a media environment that rewards fear over precision. Here's the historical anchor that makes the absence of a Sudan vaccine the most preventable failure in this story. The Zaire Ebola virus vaccine, Ervebo, was developed following the 2014 West Africa epidemic. The political will, the emergency funding, the accelerated regulatory pathways, all of it was generated by the scale of the crisis. 11,000 deaths, 4 countries affected, cases exported to the United States and Europe. The crisis produced the resources that produced the vaccine. The Sudan strain has never produced a crisis of that scale. Not because it is less lethal, its case fatality rate is comparable to Zaire in some outbreaks, but because its outbreaks have been smaller, geographically contained, and predominantly in countries that do not generate the international political attention that West Africa's scale produced. Uganda's 2022 outbreak, 55 deaths. Contained within the country, no exported cases confirmed. A real tragedy for the families of 55 people. Not sufficient to generate the political will for emergency vaccine development funding. The Coalition for Epidemic Preparedness Innovations, CEPI, was founded in 2017 specifically to address this gap. To fund vaccine development for pathogens that the market would not develop vaccines for because the outbreaks were too small to justify commercial investment. CEPI has funded Sudan Ebola virus vaccine candidates. They are in trials. The 2022 Uganda outbreak created an opportunity to test candidates under compassionate use protocols. The results are promising. The candidates are progressing. But promising candidates in trials are not a licensed vaccine. They cannot be deployed at scale. They cannot protect health workers across an affected region. They cannot be used to build the ring vaccination firewall that has been the most effective tool for containing Zaire Ebola virus. The gap between a vaccine candidate in trials and a licensed vaccine deployable at scale is measured in years and hundreds of millions of dollars. Every previous Sudan outbreak ended before the funding materialized. The next Sudan outbreak will begin with the same gap still open. Because funding for vaccine development follows crisis. And the Sudan strain has never produced a crisis large enough to fully close the gap before the outbreak ended. There are 3 ways to read the threat that Sudan Ebola virus represents right now. The global health security architecture built after 2014 is substantially better than what existed before. In-country laboratory capacity has been built in the highest-risk African countries. Field epidemiology training programs have expanded the workforce available for outbreak response. The WHO's emergency use listing process allows candidate vaccines to be deployed before full licensing when the outbreak creates a clinical trial opportunity. Contact tracing technology has advanced significantly, and the fundamental biology of Ebola, its transmission through direct contact with symptomatic individuals or their bodily fluids, makes it containable in a way that respiratory pathogens are not. Under this reading, a Sudan Ebola virus outbreak, even one that produces an exported case in the United States, is a serious public health event that the global response system is equipped to manage without pandemic-scale spread. Its weakness: every contained Ebola outbreak was contained by the specific decisions made in real time by specific health workers in specific locations, not by the system being inherently containment-proof. Under this reading, the absence of a licensed Udan vaccine is not an unfortunate gap in the product development pipeline. It is a market failure and a political failure, the predictable result of a global health funding model that responds to crises rather than preventing them. The Sudan vaccine candidates exist. The trials are ongoing. The science is solvable. What is missing is the emergency authorization of resources at the scale that would push a candidate through accelerated licensing before the next major outbreak, rather than deploying promising but unlicensed candidates under compassionate use protocols during a crisis. The cost of fully funding Sudan Ebola virus vaccine development to licensure is a fraction of the cost of the response to a major exported outbreak. The 2014 West Africa epidemic response cost approximately $3.6 billion in international assistance alone. A fully funded Sudan vaccine program would cost less than 1 year's interest on that response cost. The decision not to fund it at emergency scale is not a scientific decision, it is a political calculation about which risks deserve preventive investment and which are left to crisis response. The previous Sudan Ebola virus outbreaks have been contained. Each one has ended before becoming the scale of the 2014 Zaire epidemic. Under this reading, that pattern is not guaranteed to continue. It has continued because of specific epidemiological conditions. The outbreak was identified early enough. The affected communities were geographically isolated enough. The movement patterns allowed containment. None of those conditions is guaranteed in a future outbreak. A Sudan Ebola virus emergence in a higher density urban environment, in Kampala, in Nairobi, in a secondary city with a major regional airport, with no vaccine to deploy, in a population with the movement patterns of modern urban Africa, could produce transmission chains that the contact tracing system cannot outrun. Not inevitable, not even probable in a single outbreak. But the tails of the distribution, the scenarios where containment fails, are the scenarios for which the absence of a vaccine is not an inconvenience. It is the decisive factor. Here is what the WHO knows. Sudan Ebola virus is a recurring threat. It has caused 8 documented outbreaks. It will cause more. The response system has contained every outbreak so far. Here is what the WHO cannot guarantee: that the next outbreak has the same containment characteristics as the previous ones, that the delay between first case and notification will be short enough to prevent significant exportation. that the candidate vaccines currently in trials will reach licensure before a major outbreak requires them at scale. And here is the deepest unknown, the one that sits in the structure of the problem rather than in the data of any specific outbreak. The global health security system was built and funded in the years following the 2014 crisis. Systems built in crisis are funded in crisis. In the years since 2014, with no comparable crisis to maintain political urgency, the funding has been inconsistent. The workforce has not expanded at the rate the risk warrants. The candidate vaccines have advanced, but not reached licensure. The question is not whether Sudan Ebola virus can be stopped. It can be. It has been. The question is whether the resources required to stop it will be in place at the moment they are needed, or whether they will be mobilized in response to a crisis that has already begun. Global health security has one operating principle that has been demonstrated repeatedly. Preparation costs less than response. And the decision about whether to prepare is made in the years between outbreaks, in budget sessions, in congressional hearings, and WHO governing body meetings, by people who are not sick, in rooms where nobody has Ebola, deciding whether an invisible risk deserves visible resources. That decision is being made right now, in the absence of headlines, because the outbreak that would generate the headlines has not happened yet. In October 2014, a man died in a Dallas hospital from a virus that originated in West Africa. He was not the index case of the outbreak. He was a traveler, a man who moved through the same global aviation system that moves 4.5 billion passengers per year, carrying, unknowingly, a pathogen that his country of origin was fighting while he was in the air. The system that caught it performed imperfectly at first, then better. Then it contained the chain. 2 nurses recovered. The contact tracing held. The outbreak did not expand into the American community. The system worked. Eventually, under significant strain, with significant fear, at significant cost. In 2025, the system that caught it is better than it was. The vaccine for Zaire Ebola virus exists. The field epidemiology workforce is larger. The in-country laboratory networks are stronger. The emergency coordination mechanisms are faster. And Sudan Ebola virus, the strain that kills 1 in 2, the strain that has caused 8 outbreaks across 5 decades, the strain that emerged in Uganda in 2022 and sent contact tracers racing to track international travelers, still has no licensed vaccine. The science exists. The candidates are in trials. The gap is not scientific. It is the gap between the political urgency that a crisis generates and the political urgency required to prevent one. It is a gap that is visible only in the years between outbreaks, when the last one is over and the next one has not yet begun, when the memory of the fear has faded enough that the budget for their prevention feels optional. That gap is where the next outbreak is waiting, not in the virus. The virus has no agenda. In the window between what we know is coming and what we choose to prepare for before it arrives. The ring vaccination protocol that stopped Zaire Ebola virus from spreading through communities, the firewall built from a licensed vaccine deployed around confirmed cases before the outbreak could amplify, does not exist for Sudan Ebola virus. The next outbreak will not wait for the trials to complete. It will arrive the way every outbreak arrives, with a fever in a community among people who do not know yet what they are carrying. And the contact tracers will race the incubation window. And some travelers will be in the air before they are on any list. And somewhere, in an emergency room in a city that is connected to every other city on Earth by a flight of less than 24 hours, a clinician will take a history and ask about travel. And the answer will matter more than any surveillance system that exists upstream of it. The system held in 2014. The system needs to be stronger for what comes next. The vaccine that would make it stronger is in a trial that needs to reach licensure before the next outbreak makes it urgent. That is the gap. It is measurable. It is fundable. It is closable. It has not been closed.